Hi, this is Elliot Fishman, and welcome to our part 2 of CT of the oncology patient with an acute abdomen, a pattern approach. We left off last time mentioning graft versus host disease and the potential risk to the patient with GVH. We also will mention that GVH can be confused with ischemic bowel. It can be confused with various infectious etiologies. When it's in with 100 days of transplant, it's acute GVH disease. And when it's over 100 days, it's chronic graft versus host disease. And here's just a couple of good examples. When you have graft versus host disease, typically you have long segments of bowel involved that thickened, prominent mucosal enhancement. Really, when you see in cross-section, you have that kind of ring sign, very nicely shown. Here's another example, a patient with CML and blast crisis with abdominal pain. You can see the really extensive involvement of the small bowel on the coronal and the volume rendering and cinematic rendering. You can see the vessels are going to be patent typically, but the marked thickening and edema of the bowel with submucosal decreased density is seen. Now, we also talk about radiation therapy, and in the past, radiation therapy was a common problem, particularly with colon cancer, particularly cecal or rectal cancer. Now, because of new therapy plans with radiation therapy, this is a lot less common, but it still can occur. You can have acute processes of radiation-induced bleeding or obstruction, or you can have chronic processes with adhesions and bleeding and obstruction as well. Again, the clinical history is very, very important. Where the radiation ports are, you often can see that. You can see involvement of the kidney, liver, pancreas. But again, the frequency of radiation-induced complications is substantially lower than it was in the past. Now, we talk about this whole spectrum of processes from graft versus host to ischemia to adhesions to radiation therapy. Again, it's kind of a challenge. Radiation therapies, again, knowing the clinical history and knowing the radiation ports, and then knowing where the bowel is abnormal and matching the two of them together. So when you have a question, speak to the radiation therapist. They indeed can be very helpful to help you reach the right conclusion. We also talk about chemotherapy, which is critical for, cancer control. But again, the challenge we have, and we are developing new agents, is it injures the abnormal cells, the cancer cells, but also normal cells. And again, diarrhea and constipation are symptoms. Neutropenic enterocolitis is a complication of chemotherapy. And again, it can occur with abdominal pain, nausea, bloating, and diarrhea. And again, the appearance can be challenging, looks very much like ischemia, can almost look like graft versus host disease. So again, in dealing with the oncology patient, knowing the clinical history is important. Here's a patient with suspected GI bleed, is an ALL patient. You see thickening of the stomach. You see lots of thickening of multiple small bowel loops for a significant portion of the small bowel. There's haziness in the mesentery. There's some ascites present. Here you can see on the cinematic rendering that the vessels SMV, SMA are patent. So ischemia is unlikely, but very long segments of small bowel are involved and very impressively involved. And when I see extensive involvement like this, when the clinical history says bone marrow transplant, I'm going to worry about graft versus host disease, which indeed this was. Here's another patient with graft versus host disease. Patient had myeloma, was treated with a BMT. You can see fluid-filled large bowel, but then the thickening and cross-section of multiple small bowel loops. You track downward, you can see, again, extensive involvement. One of the things about graft versus host, it's not just like 3 to 4 centimeters. It's fairly extensive. Here you can see the extent on the coronal views. Again, we talk about this, how coronal makes it easier to see extensive processes and look for the beginning and end of the process. And again, the same thing is true. The coronal projection using cinematic rendering works very nicely. And you can see as I adjust the parameters, the ability to see the cross-sectional appearance of the small bowel, the induration of the mesentery and involvement, very, very nicely shown. Another patient, again, abdominal pain. You can see the thickened small bowel. Looks very similar to the last case. Very extensive involvement. And again, many of these cases look very similar. I think part is looking at the appearance and then thinking about if the patient had bone marrow transplant, it's graft versus host disease. If the patient had radiation, it could be radiation enteritis, but this is too extensive. Infectious etiologies, patients who are on immunotherapy are all again going to be the possibility. So at times the bowel appearance on CT looks very similar, but it's the history that helps you reach the correct diagnosis. You can see in this case lots of fluid is present in the patient's right colon, and this is due to the diarrhea or enteritis from the patient's primary process, which in this case as well is going to be graft versus host disease. Again, prominent mucosal enhancement, often low density in the submucosa. Patients with graft versus host disease can have bleeding, can have perforation, can have obstruction. So again, just a really nice example, very much like the prior case of graft versus host disease. And again, we saw processes like GVH much more commonly in the past. Fortunately, there are new medications that can be given to the patient to help limit or eliminate the presence of graft versus host disease in many cases. Here's a patient with acute lymphoblastic leukemia. You can see the dilated loops of bowel. You can see in this case, the patient had chemotherapy-induced bowel injury. And again, the challenges between the various processes, chemotherapy, radiation therapy, and then bone marrow transplant with graft versus host are all, in a sense, iatrogenic problems. Another patient, acute abdomen, oncology patient, multiple thickened small bowel loops proximally, haziness in the mesentery. You can see it very nicely. So I'm thinking, could this be ischemia? Could this be inflammatory? Could this be graft versus host disease? But that's usually distally, but we could think about it if the history matched. Could this be ischemia? Could this be chemotherapy? This thickening in the cecum, so again, you at least think about typhlitis. But look at the extent of the bowel involvement from the first through fourth portion of the duodenum, the haziness in the mesentery, the involvement in the jejunum, very nicely shown as well. And when you look at all this together, this was a patient who was post-bone marrow transplant for lymphoblastic leukemia. Again, graft versus host disease. Now we talk about VEGF and the importance in tumor angiogenesis. We talk about many of these medications and their challenges, right? Their increased incidence of perforation, fistula, necrosis, and bleeding. Imaging features are based on the complications that arise post-treatment, for example, SBO or perforation, ischemia or fistulous changes. So again, chemotherapy and the type of chemotherapy the patient is on is critical for the radiologist to know. We also talk about non-chemotherapy medications that are used in cancer patients, including analgesics, which can cause problems including renal injury and liver injury. We talk about steroids. We talk about non-steroidal and anti-inflammatory drugs. Again, can cause small bowel injury, can cause gastric injury, can cause colon injury. Again, the therapy and the treatment can all be problematic. In cancer patients, it's really challenging for the radiologist. There's no doubt that it's not an easy diagnosis. I think Again, good studies, water as a contrast agent, IV, and you can see the presence of disease in bowel. You look at other organs as well, see what's going on, but again, then trying to figure out, am I dealing with a complication that has nothing to do with the patient's cancer? Am I dealing with chemotherapy or radiation therapy or bone marrow transplant complications or other potential complications? Here's a patient post-Whipple's procedure for a serous cystadenoma and uterine cancer and radiation therapy. The patient now has thickened bowel with mucosal changes secondary to radiation therapy. Again, this was several years out from the radiation therapy. Pneumatosis that we always worry about representing infarcted bowel or ischemic bowel, but in patients occasionally with graft versus host disease, it can be seen due to the patient's high-dose steroids and chemotherapy. So not every patient with pneumatosis has ischemic bowel. Here's a nice example of pneumatosis involving the patient's large bowel, particularly the transverse colon, nicely shown on the lung windows and very extensive. This patient was mildly symptomatic. Again, if you had that much air and you've had infarcted bowel, patient would be really sick. The air looks well defined and marginated, and so in this case, I know there was pneumatosis, but I felt it may be benign pneumatosis. But again, you look at the clinical history, you look carefully at the patient's lactate levels. You need to be very careful because these are very difficult and very challenging patients. Another patient, pancreatic adenocarcinoma, Whipple's procedure, increasing abdominal pain. You see multiple loops of small bowel that are thickened, particularly distally. Again, it looks a little bit like Crohn's disease. It looks a little bit like ischemia. It looks a little bit like graft versus host disease. If you only look at the cross-section of the bowel, that so-called target sign, you can see the loops here are adherent to each other, the distal ileal loops. And that appearance to me, when I see the loops being close together like that, I'm always thinking about radiation as a possibility. It's not going to be definitive. Again, you might think of the other possibilities from chemotherapy. This was not a case of graft versus host disease, but infectious, inflammatory ischemia. But again, therapy, and this could be radiation if radiation was done, but clinical history said there was no radiation. This was due to chemotherapy. So chemotherapy can yield enteritis, can be fairly extensive or fairly focal, and can be a very challenging diagnosis. Here's another patient with rectal cancer, increasing abdominal pain, thickened small bowel, very prominent vasa recta, and you can get very prominent vasa recta in radiation enteritis, but not this prominent, in treatment related to chemotherapy, in patients with graft versus host disease, but the bowel doesn't look quite like GVH. So again, you need to think about the clinical history. So concluding then, the acute abdomen, the oncology patient, has the classic problems that all patients have in the acute abdomen: appendicitis, diverticulitis, ulcer disease, but then has the unique things from graft versus host disease to infectious colitis, to things related to chemotherapy or radiation therapy or immunotherapy. CT plays a key role in managing these patients. And again, the acute abdomen is 40% of presentation in the oncology patient. So it's very, very important that we understand the possibilities. I spoke only about the small bowel. I didn't go into the colon and some of its complications. I didn't speak about the spleen. I didn't speak about the liver, the pancreas with pancreatitis, or the adrenal glands, at times with bleed or other complication. So again, think about all the organs. Look carefully at the images. You must look at the axial. You must look at the coronal. And as I showed you, sometimes the 3D can be very helpful. And with that, I'll stop there, and thank you for your attention. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.